Symptom diagnosis of colorectal cancer. Symptoms associated with the colorectal cancer include lower GI bleeding, change in bowel habits, abdominal pain, weight loss, change in appetite, weakness, and in particular obstructive symptoms are alarming. However, apart from the obstructive symptoms, other symptoms do not necessarily correlate with the stage of the disease or portend a particular diagnosis. Physical examination may reveal a palpable mass, bright blood per rectum, usually the left-sided colon cancer or rectal cancer, or melena seen in right-sided colon cancer, or lesser degree of bleeding like hemoccult positive stool. Adenopathy, hepatomegaly, jaundice, even pulmonary signs may be present in metastatic disease. Obstruction by colon cancer is usually seen in the sigmoid or left-sided colon with resulting abdominal distension, constipation, whereas right-sided colon cancer may be more insidious in nature. And complications of colorectal cancers include acute GI bleeding, acute obstruction, perforation, metastasis with the impairment of the distal organ function. Lab values reflect iron deficiency, anemia, electrolyte derangements, liver function abnormalities, and the CEA may be elevated and is most helpful to monitor post-operatively if reduced to normal as a result of surgery. An evaluation should include complete history, physical examination, family history, lab test, colonoscopy, pan, body, CT. For rectal cancer, additional imaging technique like MRI, endoscopic ultrasound utilized for further characterization of the primary lesion radiotherapy. And while transabdominal ultrasound is not routinely used in the staging of colon cancer, recent advances in the technology as well as its value as a highly cost-effective and non-invasive means for evaluating whether abdominal tumors has prompted new interest. And one of the first studies to report on the role of transabdominal ultrasound in the preoperative assessment of colon cancer, Shibashaki et al. Found an overall T-staging accuracy of 64%, which increased to 89% when the three-tier approach was used. And out of 98 biopsy-proven cancer, all but 2 were detected by ultrasound. And while still investigational, this technique could prove to be an important alternative adjunct to existing staging protocol. And upon completion of diagnosis and staging of both colon and rectal cancer, it is essential to incorporate an expertise from medical radiation surgical oncologists in order to formulate and implement an optimal treatment plan. With the advent of molecular biological technique, attention has been drawn to stool-based tools and new blood-based tests. Technology now exists to extract genomic DNA or protein from stool and assay for evidence of genetic alteration, and large-scale validations studies are in progress, including one described study at automated multi-target DNA assay, stool DNA assay, fecal IHC test with 90% specificity and 98% sensitivity for the detection of colorectal cancer, as well as 83% sensitivity for advanced adenoma with high-grade dysplasia. EpiProColon blood-based test. EpiProColon was shown to be non-inferior to fecal IHC testing in preliminary result from a multi-center double-blinded comparable study. And one particularly attractive pathway for stool-based diagnosis would be able to stratify patients as high, moderate, low risk for colorectal cancer and thus influence screening modalities and frequency of screening. In a complementary fashion, functional genomics are being applied to pairwise comparisons of normal colon and colorectal cancers to sample the entire human genome of nearly 30,000 genes to discover those genes, known and novel, that may be upregulated or downregulated and possibly linked to detection, prognosis, and therapy. Now, screening. So, debate is vigorous as to the best approach for screening, and multiple factors influence that decision, simplicity, and rapidity, so as to enhance patient compliance, benefit to risk ratio, sensitivity, specificity, cost effectiveness, and other economical factors. And to debt, currently optical colonoscopy that is likely to be the most effective approach when considered for all other factors. An average risk patient is defined as man, woman above the age of 45 without a personal or family history of the adenomatous polyp or colorectal cancer and absence of any occult or acute GI bleeding. So this is the definition of average risk individual who should undergo screening. So screening by optical colonoscopy is currently the most sensitive method for screening. An advantage include direct visualization with the ability to remove polyps and rate limiting factor of size and anatomy, location, and to obtain biopsy. Disadvantage include involvement of the preparation, invasive nature of the procedure, potential side effect include perforation, and the digital rectal examination should be a part of general physical examination. Anorectal masses may be palpated. Flexible sigmoidoscopy does not require conscious sedation and hemodynamic monitoring and will typically allow visualization of the rectum, sigmoid colon, descending colon, and splenic flexure. Flexible sigmoidoscopy should not be considered as a single screening method but requires coupling with the barium minima. Barium minima allows visualization of the entire colon. Experience is necessary to ensure proper visualization of the rectum. Barium minima affords the advantage of ease of preparation, lack of conscious sedation and hemodynamic monitoring, ability to visualize polyps and mass, and however small polyps may be missed. And if a luminal polyp mass is identified, then colonoscopy will be necessary for polypectomy or biopsy. New non-invasive technologies such as CT, MRI, colonography, they are receiving increased attention to clinical studies and which demonstrate overall feasibility as well as some advantage. And the meta-analysis published in 2011 provides strong support for the implementation of CT colonography as a viable alternative to the optical colonoscopy in both average and high-risk population. In 2000, there were 4,800 patients, 80 patients asymptomatic. D. Han et al. Estimates sensitivity 82% and 87% and specificity of 91-97% for adenoma of more than 6 and more than 10 mm respectively. In a complementary analysis looking exclusively at the cancer detection, Picard et al. Conclude that CT colonography is not only clinically evident to colonoscopy but perhaps even more suitable for initial investigation given consistently high sensitivity without heterogeneous across 49 studies and 11,000 patients despite wide variation in technique. Another report suggests advantage of long-term cost and compliance, although these issues remain controversial. CT colonography may offer improvement in preoperative staging as one study found this technique to be highly predictive of T3, T4 tumors. Whether this information will provide is clinically relevant in colon cancer as it is for the rectum remains to be seen. Another alternative to optical colonoscopy which may be more acceptable to the patients are even CT colonography and is the colon capsule that is PIL-CAM colon 2 is now in its second generation and is reported to have sensitivity of 90% for detection of the significant lesions. And while a bowel preparation is still necessary, this technique requires no intubation, insufflation, sedation and a minimal complication rate. In a study of patients unwilling or unable to undergo colonoscopy, Negrano et al. Reported capsule to be effective in detecting clinically relevant lesions with a very high acceptability rate. And another study which compared CTC and capsule to be colonoscopy, Rondonotti et al. Reported nearly equivalent accuracy rate of both modalities in patients with positive fecal occult blood test and polyp more than 6 mm. 78% of the patient preferred the capsule over CTC or colonoscopy. And this further research is necessary on the long-term benefit, cost and efficacy. Thank you.